record on this computer. Good morning, everyone, and welcome back. Here we are in the course in bioethics, looking at bioethical issues at the end of human life. Our second lecture on this series. So always beginning with a little prayer. In the name of the Father, the Son, and the Holy Spirit. O Lord, send forth your Spirit, and we shall be recreated. You shall renew the face of the earth. Amen. So, okay, any questions, comments from previous lectures or anything? I have a comment if no one else does. Right, so it's a little side issue, but I just want to clarify it because I was wrong. Last lecture, let's see if I have it. Give me a minute to pull it up. I need to fetch it online. Yes, it regards the causes of death from last week. I had talked about the 15 major causes of death in the United States, and then we focused on the first 5 that account for 2/3 of deaths in the United States, and then the first 2 of those account for the first 2 account for 50%, half of the deaths in the United States. Just looking for that email that has the PowerPoint. And so we're looking at the 2 major causes, which are heart attack and cancers of different types, malignant tumors. Too far away now. Give me a minute. I should have done this beforehand. No. Go back here. Okay. Let's see. Yes, here we go. PowerPoint. Okay. Right. Heart attack and malignant tumors. And on my notes of your summaries, I was making some comments as I went along, and I was putting that for heart disease, it's mostly men, which is true, right? Even though that statistic is also changing as more women come into the workforce. And I was putting as a comment that malignant tumors is mostly for women, but I was wrong about that. I wasn't really sure. And so I looked it up, and it turns out that for cancers of all types, except for the 2 cancers that are sex specific, in other words, prostate cancer for men and ovarian cancer for women, those are sex specific, all right? Except for those, excluding those, all other cancers globally, it turns out that half of men in the United States end up getting some type of cancer in their lifetime, half, 50%. Whereas for women, only 1/3 of women end up getting cancer in their lifetime in the United States, 1/3. So that means that also malignant tumors is more prevalent in men than in women in the United States overall. And I was curious about that. And it turns out that it is because of the X chromosome and X inactivation in women. X inactivation, I don't want to get into many details, but basically, you know that the sex for mammals is determined by the X or the Y chromosome. And what we have there is women, as we know, have XX chromosomes in every cell of their body, whereas the sex chromosomes for men is XY, all right? So at the end of the day, it is the Y chromosome that determines whether the zygote is going to be a boy or a girl. So it's determined at fertilization. 50% of the sperm are X sperm and 50% are Y sperm. So it just depends which sperm fertilizes, if it's an X sperm or Y sperm that fertilizes the egg, because the egg only has X chromosome, right? Since women have XX, when oogenesis happens, when gametogenesis happens, the production of the egg, that egg can only have an X chromosome. Whereas in men, because we have XY chromosomes, including the cells in the testicles that make the sperm, 50% of the sperm will end up with an X chromosome and 50% will end up with a Y chromosome in spermatogenesis. Okay, so we covered that a while back. Now, what happens in women, all right, is that one of the two X chromosomes is inactivated. It's called X inactivation. And this is just a basic lecture in general biology from back when you got your bachelor's in whatever field. General biology is one of the requirements. Sometimes even in high school it's taught. But basically, for women, for females in general, for all females mammals, one of the two X chromosomes is inactivated early on in the first few at the moral stage, basically. And that is so that there's not a double expression. It turns out that the X chromosome has about 800 genes in it, about 800 genes more or less. Whereas the Y chromosome has very, very few genes. It's mostly just the genes that direct maleness, all right? So one of the two X chromosomes in the female morula is inactivated, and it's at random. It could be either the paternal X or the maternal X, right? It's random, but it comes out that all cells in the morula will have one of their X chromosomes inactivated, and then that's inherited. That inactivation is inherited, so that when mitosis occurs, that inactivation is transmitted to the two daughter cells, so that they end up with only one active X chromosome and one inactive, all right? And that makes sense, so that it prevents an overload of those 800 genes, an overexpression, all right? And that would cause grave abnormalities. It would cause for basically what we would call a super female, right? Because it would have a double dosage of those 800 genes if they all express, and it's too much. So one of those two chromosomes, one of those two X chromosomes has to be inactivated. Nature has figured it out in evolutionary time, and it happens normal in every normal female of the mammals. And that little, basically that one of those two X chromosomes is crumped up into a little ball, very tightly closed, shut down, and it's called a bar body, B-A-R-R, okay, a bar body. And that stays in the nucleus of the female. So every single female in every single one of her cells, in the nucleus of every single cell has an X chromosome that's active and another X chromosome that's inactivated. That's a bar body, a little crumped up, very closely shut down X chromosome. But that, it turns out that whereas in the male, the X chromosome stays active, basically, all right? Now, that bar body is shut down, but it's not 100% shut down. There's actually about 50 genes of those 800 that still express, all right? And they're actually necessary. And that generates a backup for those 50 genes. And a number of those genes are tumor suppressor genes. So if you think about it, again, functionally, right? I tell my students always think functionally. Women, in every single cell of their body, will have an active X and a bar body. Men, we will only have an active X chromosome and no bar body because we have a Y chromosome instead. That is also active. All right, so think functionally. Of those 800 genes in the X chromosome, about 50 of them are tumor suppressor genes. In other words, they code for proteins that attack abnormal cells, abnormal cell growth, which is basically a tumor, right? Abnormal cell growth is when cells are undergoing mitosis and they don't stop. They don't stop undergoing mitosis, they keep going and they generate a tumor. Whereas normal cells, when they touch each other, there's an inhibition that occurs so that they don't continue to undergo mitosis, right? And so tumors can be seen as an uncontrolled growth of cells. And there are tumor suppressor genes. In other words, there are genes that regulate that. And when they see that a cluster of cells is getting out of hand, they're just growing uncontrollably, they're undergoing mitosis, those tumor suppressor genes express and their proteins shut down those cells, essentially, all right? So that the tumor doesn't progress. All right, so they're called tumor suppressor genes. And it's about 50 of them, and they are, perhaps they're in other parts of the genome, but they are in the X chromosome also. And those 50 don't shut down. In the bar body, they still remain active. Interesting. So the shutdown is not 100%. The inactivation is not 100%. I guess statistically, it's about close to 95%, right? Because 50 out of 800 comes to about 5%, more or less. 40, I guess, would be 5%. Anyway, think about this functionally. Men and women have both one active X with those tumor suppressor genes that express when needed, all right? But in men, since we don't have a bar body, we only have that one copy. But in women, because they have a bar body, they have a duplicate of those 50 suppressor genes, tumor suppressors. And so they can also express. Therefore, whenever there is a mutation, let's say, in the X chromosome of men, in those tumor suppressor genes, they get taken out. You know, so the tumor suppressor genes in men are more susceptible to mutation. In women, for the same general exposure to UV and toxic chemicals, etc., over a lifetime, since they have a backup, if they get a mutation in one of those tumor suppressor genes, let's say in their X chromosome, they have a backup in the bar body. Likewise, if they get a suppression, if they get a mutation in the bar body of the tumor suppressor genes, they still have the X chromosome active copy, right? So having a copy of those tumor suppressor genes translates over a lifetime that women end up getting a little less cancer than men, about 1/3 less, okay? And that's statistically significant. And so the overall picture of this is that about 50% of men in the US end up getting some type of cancer. It doesn't have to be life-threatening, you know, but it can compromise health. Plus there's treatment, etc. So 50% of men, but only 1/3 of women. even accounting for the increase in the workforce and the increase of stress and et cetera, that 1/3 remains, which means that is less directed by environment than by genetics, right? So we have always that discussion, nature or nurture. Which one is it, nature or nurture, right? Well, it's the combination of both. And in this case, it's the nature that prevails, because in women, they have essentially a copy of those 50 or so tumor suppressor genes in the bar body, whereas in men, because we don't have bar bodies, we don't have that copy. All right. So I was wrong in saying that the second largest cause of death in the US is mostly women. I was wrong about that. Actually, what I was thinking in my mind was breast cancer, right? Which is can happen in men also, by the way, you know, but it's very rare. Breast cancer in men is really very rare, but in women is pretty prevalent. And that goes into a whole lot of discussion that has bioethical implications, because there is enough evidence out there now that contraceptives, specifically the pill, right? So chemical contraceptives fooling around with one's hormonal levels in women have a slightly higher increase in breast cancer, all right? So there's a lot of evidence. You can get it online and check it out. There is now evidence, because now it's been decades that the pill has been around, that in general, women who are on the pill have a higher risk for breast cancer than women who have never been on the pill. But that was in my mind when I was looking at that breast cancer is much more prevalent in women, and it's pretty life-threatening, right? It's a pretty aggressive type of cancer. All right.
Father, it's Jose. Just
Jose.
a quick question. Good morning. The gamete, female gamete, that has the 2 X chromosomes, is one the expressed X chromosome and one the same chromosome content as the bar body, which then compresses?
No.
Okay.
No, look at where the confusion is. You're saying that the female gamete, in other words, the egg, right, the ovum, has 2 X chromosomes? No, because gametogenesis has already happened, and therefore there has been chromatic reduction.
Okay. Right.
In other words, eggs only have 1 X chromosome, whereas sperm will only have one sex chromosome, but it could be either X or Y. So that's the difference there. You know, once we have gametes, we're haploid, right? We're looking at haploid cells. So there's no backup. Okay.
Got it.
But the interesting thing is that our X chromosome, the male X chromosome, remains active. And so the sperm primordia, the primordial cells that we have in our testes, in our testicles, that produce sperm, you know, those primordial cells are diploid, but they're going to undergo meiosis. And that's how we end up with the 50% X sperm and 50% Y sperm, just looking at the sex chromosomes.
Got it.
All right. So really at fertilization, a lot happens at fertilization, and it's all very chemical, very mechanical, and very arithmetical, very arithmetic. Okay, that's a normal, that's speaking normal. I'm talking to the norm, okay? Because we know that there are abnormalities, especially through a process called aneuploidy, where chromosomes of whatever, whether they're the autosomes or the sex chromosomes, they tend to stick during meiosis, especially meiosis 2. They tend to stick and they can add extra chromosomes. Or if it's the egg that lost the stuck chromosome, then that egg could end up with an O right, with a 0. So we have abnormalities that come up. Some of the abnormalities could be in XX chromosomes. On the sex could be XXY or XYY, right? Or on the lac, it could be XO or YO, the O meaning 0, that there's one of the chromosomes missing. That's for the sex chromosomes. And the same similar argument can be made also for the autosomes. In other words, for the other 22 chromosomes, 1 through 22. And in fact, the classical one is trisomy 21, chromosome 21, and one extra chromosome, right? Which makes trisomy would be 21, 21, 21, three chromosomes of 21, which makes for Down syndrome, right? Okay, but I'm speaking to the norm. There are always abnormalities in nature. They tend to get selected out, sometimes in embryonic development, sometimes later in life. Okay? All right, Peachy Keen, let's go forward. Now, so today we're covering actually kind of 2 lectures that are shorter. They're about an hour and something, an hour and 15 minutes each, more or less. One is on the unconscious states, and the other one is on the determination of death. All right. And so it's a little bit of a follow-up on vital organs, as we were talking about vital organs last lecture, introducing the end-of-life issues. And the organ, the vital organ that is going to be prevalent on the background of these 2 shorter lectures today is the brain and the brain stem, mostly, all right? But also has repercussions on the other 2 vital organs that are also going to be determining death, which is going to be the heart and the lungs. So functionally, I'm talking about the conscious state or unconscious state, and not with regards to the brain and brainstem, and then functionally with regard to the heart, circulation, and with the lungs, respiration. So that's kind of a tie-in with vital organs and systems that we were talking about last lecture. All right. Again, you have the outline there. So basically, page 1 is mostly on the unconscious states, and then page 2 is on the determination of death. And again, you can just be filling this in as I talk. Also, I'm going to be quoting and looking at a couple of directives for each. Total of 4 directives from the ethical and religious directive, the ERDs, right? It's a document that has been in the background. I've told you several times to download it. Here, I always carry one in the pocket. This one here. Oh, I don't know if you can see the actual camera, but anyway, the ethical and religious directives for Catholic healthcare services, the 6th edition, the latest one, from 2009. You can download it for free from the internet. I've sent you the link several times. And I'm going to be using ERD 32 and 33 on the various unconscious states, especially when we talk about ordinary versus extraordinary means of life support. And then on the second part of the lecture, ERD 56 and 57, right, for end of life, for, again, ordinary and extraordinary, but with regards to end of life specifically. So these ERDs in the 30s apply to healthcare in general, whereas these ERDs in the 50s apply to end of life, right? So this come out of section or part 5, and this is part 3. Okay, so back to the unconscious states. And here, the one that we're going to be concerned with mostly is going to be persistent vegetative state, PVS, right? But we have to see the big picture first and the broader background. So we're going to look at various states of unconsciousness, coma, PVS, TBI or traumatic head injury, then brain hypoxia or anoxia, which is lack of oxygen to the brain, epileptic seizures, syncope, which is just a fancy word for fainting, and then some other unconscious states. Before we do that, we have to look at what is meant by unconsciousness. So what is meant by being conscious, right? Because unconscious is lack of consciousness. So let's go there. First of all, to define consciousness clinically, is aware of self and the environment. So you notice there is something internal and external going on simultaneously. We're aware of self. Right now, hopefully we're all conscious, okay? And we are aware that we are aware, that we are alive, that I am here, present now in this place, right? And so are you. And so I'm aware of myself and my environment, and the external senses have a lot to do with that, with regards to the external, with regards to detecting the environment, whether I'm fully conscious of it or not. But the 5 classical external senses, right, which we can, the head contains all 5 of them, by the way, the hearing, seeing, taste, smell, and touch. Right? And then the rest of the body just has touch. But the other 4 external senses reside in the head and feed directly into the brain through mechanisms and so forth. And then the brain interprets that biochemical signal that arrives through the neurons, interprets into taste, seeing, hearing, touching, or smelling, right? So the external senses are interpreted by the brain, by the cerebral cortex, into something significant that is happening outside of us. But there's also an internal sense that generally is called the kinesthetic sense, or a self-awareness, that I am also present here and now, actively thinking, talking, listening, sensing, etc. All right. And it's safe to assume that that kinesthetic sense also resides in the brain, again, in the cerebral cortex, because we see that when the cerebral cortex shuts down for a number of reasons, we lose consciousness, right? We lose consciousness. So it's really, when we think about it, it's pretty complex what is going on in our brains right now. The active dynamic state of thinking, reasoning, and abstract thought is the highest form of mental activity. When I say triangle, most normal people know what a triangle is. Regardless of the shape, it's going to have always 3 sides and 3 angles. Okay, and so that's abstract thought. It's transmitting a thought just verbally that can be interpreted by the other person, and we understand what a triangle is, right? Without having to draw it. All right, so there are difficulties on how to measure this, how to quantify it, in other words, the metrics of especially abstract thought. And nonetheless, there is a scale that I'll get into in a minute, which is the Glasgow Coma scale that is used quite a bit clinically. So the state of unconsciousness, lack of consciousness, at least clinically, can be defined as lack of response to painful stimulus, lack of response to painful stimulus. And even painful, you can put in brackets, lack of response to stimulus in general, right? You'll see why in a minute. So we'll go right into the state of coma, which is a state of unconsciousness. And this scale that is used has been established decades now. And it's a scale that goes from 3 to 15. So trying to quantify metrics so that a clinician may say, upon presentation of a patient, is this patient in coma or not? Or I think of an ER, an emergency room in a hospital, in a clinic, and a patient presents and is, as we say, commonly knocked out, right, is unconscious. Maybe they're asleep, maybe they're in a deep coma, maybe they're in vegetative state, we don't know. So the clinician has to make a determination, right? And this scale was put together a long time ago, and it goes from 3 to 15, so that 8 or less is going to be, the patient is going to be declared in coma. So you see there is a margin, there's a range, it's a range. So 8 is halfway between 3 and 15. So anything less than halfway response is considered comatose, just clinically, right? Okay, so it's interesting that the least number totally unresponsive is 3 and not 0. That's because it focuses, the scale focuses on 3 responses, right? And the minimum for each response is a 1. It's a 1. So that we have an actual matrix, because if you add zeros, you only get zeros. But if you add ones, you come up to 3. If you add 3 ones, you get 3. Right? So basically the 3 is to account for lack of response in each one of the 3 categories. Very simple, straightforward. And this is an artificial scale, so we can make it whatever we want. All right. So it looks at 3 responses, and that's why I'm saying painful, even painful can be put into bracket, because if there's the lack of response to speech, all right, there's really no, lack of response to light, that's not painful, but it's a lack of response. So it has the eyes. Or it could be lack of response to verbal, mostly involving the hearing. And it doesn't have to be a loud, obnoxious sound like acid rock or something like that, blasted, it can be just talk, not necessarily painful, but there's no response. Now the motor typically involves pain, involves pricking the patient with a pin or something that is sharp, all right? Without having to penetrate the skin, but just touch. If we just prick ourselves with a pin without having to break the skin, we can still feel pain because the pain nerves are very much at the surface of the skin, right? Okay, so it's basically the eyes, the ears, and the skin. Those are the 3 main that are involved. The other 2 senses are a little more subtle, basically smelling and tasting. We don't want to go there. No need. Just use these other 3 external senses. So for the eye, the scale goes from 1 to 4. For hearing, the scale goes from 1 to 5. And for motor response, the scale goes from 1 to 6. And then it's a question of adding up the numbers for each response. So what I'm saying is that the clinician will test the patient on these 3 responses. First, the eyelid, if the eyelids are closed, the eyelid will be opened up and see if is it the iris that responds by diameter, right? If there is a spontaneous response to light, then that is a 4, the maximum. If there is a response only to speech, like for example, open your eyes, and the patient opens the eyes, then that's a 3. And if there's response to pain, right, which now involves the motor, the patient will open their eyes to a pricking of the skin. No response to either light, speech, or pricking, then the patient gets a 1. That's on the eye response, the iris specifically, right? The verbal, same thing with the hearing, but you can see if a person is alert, oriented, as they say, and responsive, then they get a 5. If the person is a little confused, but is not really unresponsive, they're confused, you can ask them, where are you? And they say, well, I'm walking through a forest right now. And they're not walking through a forest, they're in the emergency room, right? Or something like that. Or who are you? Give me your name. And they have to think about what their name is, etc. When it's totally inappropriate response, the typical thing, what year are we in? And we're the year 3000 before Christ. We're not really there, right? Or where are we? Well, we're not in the Colosseum. So when it's a totally inappropriate response to a verbal question, then they get a 3, but they're still alert, or they're still alert. They're not really asleep. When it's slurry, incomprehensible, then a 2, and no response, a 1, so on and so forth. And for the motor, you can see the scale 1 through 6. It's a little more detail. At the end of the day, all the 3 categories are added up, and the maximum of 4 plus 5, which is 9, plus 6 is 15, and the minimum 1 plus 1 plus 1 is 3. Again, the total score is what is looked at. 8 or less is comatose, and 9 or above is not comatose. And the different, then what happens? Now we have a diagnosis. The patient is comatose, right? There will be hopefully once we have a diagnosis, there will be a protocol, a procedure to follow. Different if the patient is not comatose. So that's the first algorithm, if you will, the first fork on the road for treatment, what treatment is proper. This also includes induced coma, right? So it can be a coma typically from a head injury. That's the classical comatose stage, right? Head injury, which knocks the person out. It could be temporary or it could be permanent, depending on severity. We'll get there. But the induced coma is when the person is alert, but needs to be put to sleep in the literal sense, not in the figurative sense of killing, right? For example, we talk about putting a pet to sleep because they're suffering, or at least they're in pain. We don't know if they're actually suffering in the human sense, but they're in pain. For example, Dolly, when she was aging prematurely and showing graphically, physically, those signs, those symptoms of arthritis and so forth, she was put to sleep, right? Well, she was not put to sleep. She was euthanized. She was essentially killed for humane reasons. So that would be an induced coma. Again, the classical example is a person with pneumonia who needs to be intubated and put on a regimen of antibiotics, which normally is a week's course, but the person needs to be, their metabolism needs to be slowed down so that the immune system can work fully on overcoming the pneumonia, right, with the help of the antibiotics. So the person may be induced to a coma, which typically involves somnifers, in other words, literally putting the person to sleep, literally, not killing the person, putting them to sleep, right? Sleeping medication, and also a muscle relaxant so that in their sleep, they're not moving around, because this may come as news to you, but in our sleep, we move around, and we move around quite a bit. If you don't believe me, just tonight, record on which side of the bed you went to bed, right? The left or the right side, and then in the morning, see what side of the bed you wake up in. Half the time, on average, you wake up on the other side of the bed, which means that we move at night unconsciously. Okay, a person intubated, we don't want that person moving around. Now, I'm interspacing here some clinical stuff also, which helps us for the bioethical analysis. And so we have now these great tools of not invasive diagnostic tools, non-invasive or minimally invasive. Is essentially either sound or magnetic waves going through our body, which they're going through our body right now, you know, and we don't, they are inert and innocuous. They don't do any damage. But now with the proper receptors and with the proper frequency and so forth, we can actually detect soft tissue of the body, which doesn't come out in X-ray. Plus the X-ray has the disadvantage of possibly inducing mutations at a particular dosage, or exposure is a combination of dosage and time, right? So we want to minimize exposure to X-rays only when needed. But we know that X-rays will detect hard tissue, essentially bone, calcified cartilage, which becomes bone. But for soft tissue, there are three main diagnostic tools. Let me just jump to that briefly. There's the MRI, magnetic resonance imaging, right? So that's the acronym and the full phrase, magnetic resonance image. You can see that they are magnetic waves going through our body, and that can slice the body down to the millimeter, and it's just a fantastic tool. There's another one called the Positron emission tomography. So this is positron, I believe, is the counter particle to an electron, right? So it has a positive charge, but it's expresses as a wave. And so that's a PET scan. Sometimes you hear about a PET scan, I guess, to detect different types of soft tissue. Not really sure. But then there's the other one, the computed tomography. Computed tomography is a CT. You hear about a CT scan, right? So MRI, PET, or CT scans allow the clinicians to look at soft tissue in great detail, and they can slice the body basically, I think about a millimeter in difference, right? Throughout the whole body from head to tail, or they can also go sideways on the body. So either vertically or horizontally, right? To look at soft tissue. So this is again an MRI for the brain. We'll come back to this one when we look at a comparison, but I want to go back up here for now with the MRI for the vegetative state. All right, so persistent vegetative state, which is also known as permanent vegetative state, or just simply vegetative state. You'll see PVS or just VS, right? First of all, it's kind of unfortunate that it uses the word vegetative, because as you can see, it's derivative from vegetable, and we're never vegetables, right? And so that's a whole different kingdom. we're in the animal kingdom, just for basic review, not in the vegetable kingdom, not in the plant kingdom. But vegetative state is just picking up from the fact that plants normally don't move, right? They don't have self-movement. So it's just a reference for unconsciousness, but long-term, right? So I think that when a person is in coma for more than maybe 3 or 4 months, please, clinicians, help me out, that person may be declared in a vegetative state, I think that's kind of the standard, 3 to 4 months, maybe. I know that by 6 months for sure, because then by 6 months, for example, Medicare can kick in and other aid that is government aid that would not be available earlier, all right? Or a person may be, because that 6 month is kind of a legal / medical limit for saying that a person has 6 months to live. You hear about that 6 months, but that's really a very arbitrary statement, right? Because no one really knows how much anyone else has to live, right? So that 6 months is just thrown out there because it's half a year, okay? But so is it about 3 or 4 months? Does anyone actually know when a person in coma for more than 3 or 4 months without response, right, will be declared in a vegetative state, which is considered long-term. Then one can be in PVS for decades, and we'll see a case, we'll see several, but one in particular, the name Terry Scheibel was, for any one of us who have been in South Florida for more than 20 years, will remember the name of Terry Scheibel. Was a very dramatic case of a person that happened here in South Florida, okay? So we'll look at that within the context of nutrition and hydration, PVS and nutrition and hydration of this patient. So, cerebral cortex activity, as you can see, fully consciousness. So when we see on the red spectrum, the red end of the spectrum, that is implying active mental activity, all right? In other words, this person is thinking actively. And so this is a very graphic example of how this MRI is not an invasive tool. This person is just thinking actively. They're even frowning a little bit here. You know, this is their skull or their face, right? Which again, skin is soft tissue, and it's colorized. So all these are different shades of gray originally in the data set, but then it's colorized for contrast. Okay. And these are just 2 examples. You see how this brain is being sliced at this particular point with no damage, no significant damage to the person that we know of, right? And comparing the 3 states. Another patient, obviously it's not the same patient because you cannot be fully conscious and minimally conscious at the same time. These are actually 6 different patients. And you can see the physiognomy changes a little bit. I mean, look at this nose compared to this nose, very different, right? So these are 6 different individuals, or maybe they do match up. I'm not exactly sure if these 2 are the same patient. Now that I'm looking at it, perhaps they are. It's just a different slice of the brain. This is closer to the earlobe, right? And this is higher, perhaps on the earlobe. This is definitely higher. So maybe these 2 are the same patient. I'm not really sure, but it's kind of a duplicate. It just shows the contrast between a fully conscious person, a person in vegetative state, and someone who is minimally conscious. So this patient would have probably like a 9 on the Glasgow scale, right? Because minimally conscious. What does it mean? That one number below, this person would be unconscious, just barely unconscious, right? So that would be what on the scale? 8. 8 is the maximum number of in a comatose stage. Okay. So what I'm saying is that this patient would probably be on a 9 on the scale. How about here? Fully conscious. This person should score what? These 2 persons should score
15.
15. Thank you, Christina. Okay. And vegetative state, this person would score what on the scale?
3 or less.
Not less. There's no less than 3.
Oh, okay, 3.
3 or 4 or 5, you know, but typically 3. All right. So that's a pretty graphic. 3, 9, 15. Okay.
So the vegetative state is pretty much when a person's completely unconscious.
Completely unconscious of the brain. I have said nothing about the brain stem, but I might as well say it now because this is obviously the cerebral cortex. We're not looking at an MRI of the brain stem, which is unfortunate. It'd be nice to have the brain stem down here, you know, but the brain stem, so this person in vegetative state is, are they breathing? Yes, they're breathing. Is the heartbeat? Yeah, the heart is beating because there's circulation and the lungs have to be alive to breathe, and which means they need circulation, right? They need blood to stay alive. And the heart also needs oxygen to stay alive. So both lungs and heart are breathing in the PVS patient. Therefore, that patient is not dead. The patient is not dead. A patient in vegetative state is not dead. Not dead. They're asleep indefinitely. You know, when we're asleep, we're not conscious. But our heart is breathing, our heart is beating, and our lungs are breathing. You better believe it, otherwise we would be dead. Okay, so that's the critical thing. A patient in PVS is not dead. Yeah, so just to finish, the heart is beating, the lungs are breathing. That patient is not dead, but that patient is unconscious, which means that the brain stem is working. It's working, and that's why I put brain and brain stem as 2 separate organs, vital organs. Here's the brain and here's the brain stem, right? This is the brain stem. By the way, the cerebellum belongs, if you want to functionally, if you want to put it to on the brain side, but it's connected to the brain, but the brain stem is the one that controls the involuntary nervous system, which controls breathing and heartbeat. Okay, questions, comments?
Father Shofi,
Yes.
give me a second, Cristina. If Dr. Martinez agree, because I want to be in the same page. You were talking about coma versus persistent permanent vegetative state.
Yes.
The main difference is that in the coma, the patient is totally gone. If you don't put what it says, the assistant with the respirator and all the functions are gone. The difference within the vegetative state is that there is the brain stem has some functions that control the respiration, the blood pressure, the heartbeat, and so this patient is alive, as you said. If you disconnect the patient on coma, it will be dying as soon as a few moments. You know, it depends on the damage of the brain. You know, but it cannot control the heartbeat. It can control the respiration.
Okay.
So it's different. So in the case of, let's mention, in the case of Sherry Shaw, he was in a permanent vegetative state.
Correct.
So, but that means they are totally unaware of the environment, of themselves and the environment. They are totally unaware because there is a totally unawareness of the environment. But they can control the temperature, they can control the heartbeat, they can control the respirations. So she was alive, she was needing only the feeding. That was the problem, the feeding tube that they were doing the feeding through the tube, you know, the PEG tube.
Right, the PEG, yeah.
And that was the reason they went to court and whatever. But she was alive.
Right. Okay, good, excellent. So this clarifies a lot for me, really, because now I see the critical value of this number down here. If the patient, upon presentation at an emergency room, for example, if the patient scores 8 or less, what you're saying that basically the protocol is to intubate, because that patient without life support will proceed to die, right?
Father, if I could interject.
Yep.
I think if we speak in general terms, then it makes the conversation obviously more level and understandable. But for nuance purposes, there is a continuum in all this. So for example, I could be in a diabetic coma, and I would not need to be intubated, and I would not die necessarily within minutes. You actually, the protocol for a diabetic coma is basically support. So like if I went hypoglycemic,
insulin,
I'm just gonna give you hypoglycemic, I'm gonna give you sugar, and I'm not gonna intubate you, I'm not going to do CPR, and you are actually
address the pathology.
Your cortical activity and your brain activity are active. Now there's brain stem, but obviously there's interaction between the midbrain, the upper cortical, and the brain stem, and they could be partially functioning, even though your expression may be at a very low score on the Glasgow Coma Scale. So the Glasgow Coma Scale is something that's partially used, but is not always the end of the response. And you showed some MRIs, and those MRIs show a point in time, but you could actually fluctuate between the level of organ activity at any one of those levels at any particular time.
I see.
So, for example, if I cool you down enough, I can put you into that kind of blue state that you see there. And that's one of the things that we do.
Yeah, hypothermia.
Hypothermia. And then, so the other components is respirations and active respirations and cardiac rhythm and induced cardiac rhythm. So for example, and we could talk about it, but this is a total sideline. I've had to turn off somebody's pacemaker to turn off their heart because we've determined that the person was dead. Okay, so there's again.
That was a neurological criterion at that point. We'll get into that in the second half.
Exactly. So I just wanted to kind of get that point out there, because these are points of discussion that occur in a lot of times in bioethics committees.
Exactly.
That they're not as straightforward as, it's this or this or this or this. From the criteria of, you were talking a little bit about the time on in coma, and when you will classify to be in a persistent vegetative state and so on, that varies a great deal, depending on what country you're in, or if you're in the European state, if you're Scandinavia, if you're in Australia, if you're in the United States. And in the United States, it kind of varies a little bit by state to state.
Also,
what defines some of those components is the when your benefits kick in due to prognosis. So the longer so the longer you're in it, your benefits may kick in, and then they may say no more benefits because you have no prognosis for recovery. And that varies again, depending on the indemnity in the state and whatever benefit you're receiving. So I just wanted to clear that up.
Absolutely, this clarifies a lot.
Sorry, Dr. Father. When I was talking to persistent coma, that is a chronic stage of lack of activity. Versus the persistent vegetative state. You are right about the diabetic coma of this.
Diabetic coma.
Exactly. I was talking about the coma that is chronic, that is most probably caused by a traumatic head injury.
More prevalent.
The patient hasn't recovered any of the functions. Is chronically ill, and some of them probably they can recover from the coma, and some of them recover totally, and some of them stays in a persistent vegetative state. That's the but you're right, Jose.
Okay, yes, Antonio, you also had a question or
The
comment?
question is like, when is it to be determined, like, you know, when a person is completely, you know, died, when they dead?
When they're dead, right? Okay, so we're looking at states of unconsciousness, which means that the patient is not dead, all right? And that's why the second part of today's lecture is the determination of death. And we'll get there.
I know where the doctor says kind of like, you know, like they don't know, like, okay, like how long, you know, when a person,
Exactly.
it's like a person can be
Exactly.
in a vegetable state for years, and then
Right.
they wake up, and
Yes.
the doctor made a choice before you, you know.
Yes.
Uh,
So the patient may be dying, but we don't really know when we die. But thanks be to God, we can tell when a person has died. So it's past, you know, past, what is that? Past participle, when the person actually has died. In other words, we can determine through a couple of criteria that now we have before us a cadaver and no longer a living person, all right? But the actual dying itself, we can't really determine that, but we can determine when the death has actually occurred, once it has occurred. So it gets a little philosophical, but we'll get there, all right? What I see interesting in this discussion is that it actually makes me think of a time history here, a historical progress of medicine, which makes sense. In my intuition, the Glasgow scale was developed years, maybe decades before the diagnostic instruments that we have, like the MRI and the PET and the CT scans, right? These are obviously much more sophisticated, probably, I think in the 80s, again, correct me if I'm wrong, but these diagnostic tools came up around the 80s, whereas the Glasgow scale probably has been around for many years before that. So now, as our doctors were saying, it's a combination. It's not just the Glasgow scale, and it's not even just the MRI, but it's the overall assessment, what we call the clinical eye, precisely, of the clinician as they look at the patient. And there is that, that clinical eye to determine and to give a diagnosis. And that's why even legally, only the medical doctors or the DOs, doctor in osteopathic medicine, and the nurse practitioners can diagnose, right? I think it's only those three categories because they are supposed to have the training of being able to look at a patient and come up with a diagnosis. Christina.
Yes, thank you, Father. So one question related to this is, so what you're saying is the person that is in this state,
which one? Coma or PVS?
No, the PVS has the vital organs of the heart and the lungs function, but how about the others, like the pancreas or the kidneys?
Sure.
That's one question that I have. So they have to be connected to some kind of machine to provide that. But the other is a comment more than a question, because the doctors here, of course, they're doctors, but I'm thinking about a person like me, and I have to deal with these situations already a few times in my life with my mother-in-law and also my mother, who passed away 3 years ago. But sometimes and I'm thinking about from the bioethical point of view, me being a lay person, because it's a very confusing discussion. How can you, I remember trying to make a decision for our mother-in-law, whether or not it was time to let her go. Right. And it's not easy. And I understand what you're showing, but for the normal person, this is not you don't understand this. You don't know what's going on. And it's hard to see the difference and to come to the point of making a decision. So I really believe that doctors and the medical teams sometimes, and I'm not saying that happens to you, but sometimes since they deal with this every day, they kind of lose, how do I explain this or express myself? The humanity that requires for a family member to come to the conclusion that it's time.
Mm-hmm.
And that's all I wanted to say.
Absolutely, right. Okay, so as to your first point, you're right. The heart, so a patient in PVS, their heart and their lungs are functioning. Those are two vital organs, but there are other vital organs, and it depends on each patient. That's why I say, you've seen a patient, you've seen one patient, you know, it could be that the patient is in PVS and also in renal failure, right? And so that patient may be on dialysis, but it's not dead. Or it could be that they have cirrhosis of the liver, and now the liver is also dying. And so you can go and we need to go organ by organ, okay? But with regards to PVS, at least if the heart and the lungs are functioning, it means that the brain stem is not dead, that the brain stem is functioning. And that's why I'm just trying to make a point that we need to consider the brain and the brain stem separately as far as the bioethics of it to be able to determine death precisely, if death has already occurred, right? So hopefully, as to your second point, yes, the main purpose of this course, of this part of the course at the end of life issues, is to give you the tools to be able to, on the one hand, engage the medical profession with some level of knowledge. So now you can ask the question, doctor, is my mother or my grandfather in a vegetative state, or are they in coma? Are they conscious or not, right? So you can ask more accurate questions and also understand the language, because not every doctor, of course, they're trained a lot to try to explain the clinical condition in non-clinical terms, in terms that you and I would be able to understand, okay? But it does take that over. And that's why I mentioned already we find discrepancy, for example, when we talk about ordinary or extraordinary means of life support, that is very bioethical language, but it's not necessarily clinical. Clinical, they'll talk about standard medical practice or experimental procedures, okay? And we have to try to bridge that gap. So hopefully, as we go forward, you will all be having more and more knowledge to be able to enter into that dialogue, all right? And to be able to make those decisions, right? So having that experience of typically elderly people passing away or going into senility, going into dementia, and so forth, from this lecture to the last one now, we have about 4 or 5 more left, will clarify a lot of this, all right? So basically, hang in there. Okay, let me move forward. Just for the sake of completion, look at a few other states of unconsciousness. For example, TBI, and some of these can lead, one can lead into the other, all right? So traumatic brain injury or traumatic head injury, okay? It's complex, it involves damage, physiological damage and also psychological damage, especially if the cortex is compromised. So it's a broad spectrum of symptoms and also disabilities. It can be temporary or permanent. I don't want to take too much time on it, but it's pretty self-explanatory. It's an injury to the head, all right? The typical thing is an accident, yes, the car accident without the seatbelt, or the motorcycle accident of the driver who flew out, the motorcycle driver who flew out into space to hit the concrete or another car or something like that. There's a nice little site. Mayo Clinic has a lot of clinical stuff that is translated into understandable language. So I always recommend Mayo Clinic for a go-to place online. Right, so you can just look up traumatic brain injury, single word, and it give you a lot of information there. There is, again, more or less, to try to quantify it, a distinction between a mild TBI or a severe TBI. where the prognosis meaning the hope of recovery, right? Prognosis is the expectation of recovery from a mild TBI is that the person will recover. So they will be unconscious, let's say originally from the TBI, they're unconscious, but the expectation is that they'll regain consciousness within 30 minutes. If the patient does not regain consciousness within 30 minutes, then it's considered that the TBI is severe. And of course, the symptoms and the disabilities are expected to be more severe and more long-term, right? So again, that's just half an hour is considered an approximate cutoff between mild or severe traumatic brain injury. Again, this is stuff that is used a lot in the emergency room or these urgent care centers where people are going when they suffer some kind of a accident or trauma. Going back to circulation a little bit, lack of oxygen to the brain, low oxygen will be hypoxia, and no oxygen will be anoxia, all right? So OX is a reference to the oxygen. The prefix hypo is low, and the prefix ano is none. Again, the classical thing here is a drowning, and very typical in South Florida because so many houses have a pool in their backyard, and the birthday party of a lot of kids running around and not enough adult eyes on those kids. The adults get distracted with their conversation. Before you know it, there's a child in the pool who doesn't know how to swim. And it only takes a couple minutes for hypoxia or anoxia, all right? And it is certainly extremely traumatizing. That's why I always advise parents who have young kids, teach them how to swim when they're babies, because the newborn is used to a liquid environment in the womb for 9 months. So they're naturally swimming for 9 months. We're all swimming for 9 months, the first 9 months of our lives. And so there's these classes that are done. It's really kind of fun and scary at the same time to watch how parents teach their babies how to swim early on. And the typical scenario is that the parents are put in a pool, shallow pool, so that everybody touches the bottom. You know, maybe it's a 4 feet or 5 foot pool. The parents are inside the pool, everybody with their swimsuits and all that. They're having, but it's not a pool party, all right? They're all very alert, and they're all facing the edge of the pool. And then the trainer will be maybe in the water also or outside, but someone has to drop that baby into the water. And when it's done young enough, the baby automatically, by instinct, will naturally, as they go into the water, they will start sinking a little bit, all right? But as they do, automatically, subconsciously, when they start getting water up their nose and maybe even up their mouth, they stop breathing. But as they stop breathing, they're also reaching to the surface. So they're kind of paddle their way to the surface, all right? And of course, then the parents are supposed to help them out a little bit and assist them, but not really just take them out of the water, because they're trying to train the baby to just tread water, to come up to the surface and to tread water. And they'll do that when they're young enough, because we still remember the womb, okay? And so that's done with babies. I don't know exactly what age, but it's within months. Once we go into 1 or 2 years old, we kind of lose that instinct, all right? And so if we don't know how to swim and we're 1 or 2 or 3 years old or older and we go into the water, we traumatize, we stop breathing, we sink, but we don't really work our way to the surface. And we just keep sinking and we drown. And so family and friends, young people, spread out the word. If you know someone who's having a baby one of the first things I want to teach that baby when they're born is, aside from collecting their umbilical cord stem cells, is teach the baby how to swim. All right. And so I say it's fun and scary at the same time to watch these classes. You can go online and see a lot of videos, but get it out there, okay? Especially you young people, for yourselves and for your family and friends, and even strangers who, you know, she's pregnant. Well, tell them about the umbilical cord cells, but also tell them about teaching their babies how to swim. Right, because this is very serious. Lack of oxygen to the brain is really bad news. It will lead to coma or vegetative state, all right? So just a little review of the circulation here. We have 3 pairs of arteries going to the brain, all right, to the head. And so it's 1 pair of vertebral brain arteries and 2 pairs of carotid arteries. The carotids are the ones that are felt by the tact. They're the ones that are sensed by the doctor to see our pulse. They can take our pulse through the neck, but they can also detect even by touch, but certainly with the stethoscope, if they're clogged or not, right? So the carotid arteries can be rimmed out of cholesterol, I believe, or plaque to open them up for circulation. A little background, I always have the temptation into getting into too much biology, but since a substantial number of you students are aspiring to medical school, just a very quick review of arteries and brain and veins. So we have 2 types of circulation functionally, and we have 2 types of circulation structurally, all right? Structurally, the 2 types of circulation are the systemic circulation and the pulmonary circulation. So systemic circulation goes to the body, to the systems of the body, to the organ systems of the body. So the systemic circulation is somatic, is to all the body, distinct from the circulation that goes to the lungs. That's the pulmonary circulation, all right? So that's structurally, either to the whole body, systemic, or to the lungs, pulmonary. But also we have 2 types of circulation functionally, in other words, by way of gas exchange. And that is the distinction between arteries and veins, So an easy way to remember, because it's not that arteries carry only oxygen, oxygenated blood, and it's not that veins only carry a CO2 blood. No, it depends. If it's systemic, yes, but if it's pulmonary circulation, it's the opposite. So an easy way to remember arteries. You see, arteries go out of the heart, out. Arteries are out. Look at the word pattern, arteries out. You can even think of the A in capital letters. A is an arrow pointing out, right? So arteries go out of the heart. There can be the aorta that goes to the systemic circulation, or the pulmonary artery is going to go out of the heart, but it's going to carry CO2 blood because it's going to the lungs. So the pulmonary artery is going from the heart to the lungs, but it's carrying CO2 blood because it's going to the lungs. Veins go into the heart. So vein, you think of the V, right? The V is pointing down. So it's an arrow pointing so veins go into the heart. So you have the vena cava that is a systemic circulation into the heart with CO2 blood, right? But the pulmonary vein is coming from the lungs into the heart. And if it's coming from the lungs, it brings oxygen blood. It brings oxygen blood, so oxygenated blood going through the pulmonary vein from the lungs to the heart to be then pumped out through the aorta for the body. All right, so that's a little aside, you got it. Brain hypoxia or anoxia can also bring a state of unconsciousness, very dangerous. Forward, seizures. Dr. Martinez already mentioned a diabetic coma or seizure, but epileptic seizure is the typical one. The event is also known as a fit, as an epileptic fit, right? It's a neurological activity, and you can see here with the EEG, the electroencephalogram, which is another measurement of brain activity. The seizure, the epileptic seizure, has all of these characteristics. First of all, it's abnormal, it's excessive, it is generalized, and it is synchronous. All right. So let's pick on generalized, meaning from all different parts of the brain, all the electrodes. They put about a dozen electrodes. I don't know how many. 2, 4, 6, 8, 10. Here are 10 electrodes in different parts of the brain, different lobes, right? And so it's generalized, and they're all firing abnormally, excessively, because it could be abnormally flat on the opposite end, right? No, but it's like normal excessive, and it is synchronous. In other words, simultaneous at the same time, right? So these are the 4 typical symptoms of the EEG of an epileptic seizure. The person is not dead, all right? But the person looks dead on the floor, totally passed out, even compromising the breathing. Because of that, historically, a number of people have been buried erroneously, thinking that they were dead, and they were not. Now, these are actual diagrams of coffins, historically, going back centuries, where because of this phenomenon, that they were thought to be dead, but were not really dead, these elaborate coffins became popular, and people would actually purchase them beforehand with literally bells or whistles or flags in case the person woke up inside the coffin. And you would hope that someone is looking at the flag outside or listening to the whistle, okay, or the bell or whistle. This is a photograph of a cemetery that has this historical tomb. I don't know how far back it goes. It even has a plaque, and I don't want to know what the plaque says, but there's the bell and the string that goes inside down into the coffin in case that poor fellow woke up inside. All right. Now, the obvious question here to ask, how do we know? Well, the how do we know is rather graphic, and I'm not going to go there, but you can certainly go online and look it up by scratch marks on the inside of the coffin. All right, that is the classical, typical thing, scratch marks on the inside of the coffin, on the inside of the top, right? Gruesome, real, horrible, but it has happened historically. But again, the deeper, how do we know? Okay, so scratch marks on the inside of a coffin top would certainly be an indication that the person woke up, right? And how do we know that? Well, because a number of coffins have been exhumated over time. And I know it, at least from the Catholic perspective, when a person is being considered for beatification or canonization, in other words, to be declared a saint, right? One of the first things that is done is that coffin is exhumated, it's taken out of the ground, humus is the ground, so being taken out of the ground to see if the body has been preserved or not by some kind of miraculous intervention, okay? And so exhumation of bodies has happened historically, and in some cases, they have actually found scratch marks on the inside of the coffin, all right, in this process of beatification or canonization. And I can tell you, take it one step further, if they do find those scratch marks, that is an automatic disclaimer for canonization or beatification, because that person may have lived a saintly life, or we call heroic example here on earth, right? As they live heroic virtues, what is called heroic virtues, that's another thing that has to be determined. You know, the person, you think of Mother Teresa, or these people who live an exemplary life, and even other people, well, Gianna Molla, right, who gave her life so that her child will have life. But if they find scratch marks on the inside of that coffin, then, you know, if that person woke up inside that coffin, there's no way out. So there's a possibility that they may have despaired, and therefore, you know, they no longer qualify, at least on the human side. God is God, and God will decide, and that person may very well be in heaven, but for human purposes, you know, there's a doubt. So if there's a doubt, then in other words, the canonization thing has to be beyond reasonable doubt. Okay, which means that most likely there are many, many more people in heaven than the ones who have been officially declared saints. And that's a good thing. That's a very good thing. All right, so there it is. I don't want to dwell on it further, but seizures have to be taken seriously, and it's important to be able to diagnose them correctly. One of the issues is the tongue start going inside, so I understand that one of the aspects of the seizure is to try to help the person not to swallow their tongue, because they can actually choke by swallowing their tongue in the midst of the seizure. And again, I show my ignorance here, but I don't know if EMTs are trained. I think some of you have had EMT training or at least CPR training. Are you also trained to hold the tongue out for a person who is in a fit so that they don't swallow their tongue? Can anyone enlighten me on that? Okay, I guess no one has had to deal with this in real life.
Father, I think we put them on their side nowadays.
Oh, sideways.
It's more for if they vomit, so they don't choke.
Vomit, right. Regurgitation, yeah. Right, regurgitation can go to have aspiration. They can get aspiration pneumonia from the, all right, so sideways and let gravity help. Okay.
And
All right. So we've done that. All right, we're going down to the wire here. Syncope, as I mentioned, is just a fancy word for fainting. And it's a temporary loss. Excuse me. Excuse me. So temporary loss of consciousness, typically it's a sudden drop of pressure, blood pressure. It's happening a bit close to it in my old age now, because it turns out that I have a low pulse. A normal pulse is maybe in the 70s or 80s pulse rate. I'm talking about the number of heartbeats per minute for normal adults, right? We should all know our pulse rate, by the way. So take your pulse anytime when you're at rest and relax, right? Typically you measure it for about 30 seconds and you multiply by 2, do it several times, get the average. But we should all know our pulse, our resting pulse. And the typical resting pulse is maybe in the 70s or 80s, meaning the heart beating 80 minutes per minute, 80 times per minute. However, some people have a lower pulse rate and some people have a high pulse rate, right, which can lead to possibly hypertension. But low pulse rate is just a natural thing. It's off the norm. It's on the low side, and my pulse rate is in the 50s. You have a low pulse rate too? Yes, resting pulse in the 50s, normal, right? For Antonio and I. Now, this is the thing. The clock only moves forward, right? And when we're young, a low pulse rate is an advantage. It's actually known as an athletic predisposition. It doesn't mean necessarily that we're going to become athletes, but we have an edge, we have an advantage. Why? Because let's say a normal athlete with a normal pulse rate of 80, what is good exercise? What is a good cardiovascular workout? A good cardiovascular workout, right, is to raise your pulse about 50%. That's why we should all know our pulse. Raise our pulse 50% and keep it there for half an hour. Okay, so it's simple arithmetic. What's 50% of 80? 40, right? So 80 plus 40 is 120. So you're on the treadmill, or you're a stationary bicycle, or you're jogging, and your iWatch is telling you your pulse rate, and you start at 80 resting. So now you're up to 120. So now you're doing cardios, right? And you keep it there for half an hour. That's a good workout. Of course, you build up to that and you build down from that, et cetera, et cetera. But so, you know, at 120 heartbeat, we're pacing ourselves. We are breathing heavier, deeper, and so forth, right? So we're taxing the heart somewhat. We're taxing the heart 50% for half an hour. Now, take Antonio and I, who start at the treadmill with a pulse of 50. So we raise it 50%. 50% of 50, 25. Plus 50 is 75. So when Antonio and I raise our heartbeat 50%, we're at a 75%, not 75%, 75 heartbeat per minute, which is within the normal range of the heart. So piece of cake, no stress. You know, we can be on the treadmill half an hour or 1 hour or 2 hours because we're just raising our heartbeat to what is normal for the heart. And that gives an advantage. I remember one time, a few years back, when my GP, my general practitioner doctor, wanted to get a baseline. I guess I was in my, I was probably in my late 50s or something like that, and he wanted to get a baseline. So he did a stress test on me, not induced chemically, but with a real treadmill. All right, so he sent me to one of these diagnostic centers, and I would get on the treadmill, and they stress me to take my heart to almost pre-arrest. You know, that's the stress test is pretty stressful, but there are technicians around you, and they may even be a clinician on site that are monitoring, so they're monitoring your heart rate as it's going up, right? And on the treadmill, they increase the incline and they increase the rate of the treadmill to stress the heart, and they do it slowly and monitoring second by second the vitals. And so they took me to that pre-arrest stage, right, to see how much stress my heart could tolerate. And then when they reach that limit, of course, they take you down, right? So they tone down the slope on the treadmill and decelerate simultaneously and all that. And I remember distinctly the technician who was following me, right, all my vitals live there in live time, telling to the other fellow who may have been the clinician, called him and said, look, and he was pointing out at the fact that I was going back to normal very fast. I was restoring to normal, my normal resting pulse very, very fast, you know, faster than the average person. And so he was impressed by that. He said, look how fast he's going back to normal. And it's just genetic. I have no merit. That's the way that my parents knit me when they created me, okay? And so it's just a condition, this low pulse rate, which when young is an advantage, especially if one gets into sports. But as old, it flips to a disadvantage, because what happens is that my heart rate continues to be low in my old age and maybe slow down even a little bit more because the heart is getting old and it's a pump that has been pumping for decades and decades, minute per minute, you know, and so it may even slow down even a little bit more. And my circulation is not as good. The overall thing with old age, Antonio, to look forward to is that with a low heartbeat, with a low resting pulse, with all the age, the circulation is not as efficient on the brain. I don't get as much oxygen to the brain, especially with sudden movements. And it's happened to me several times now that I've been in the forest, you know, that I do work in the forest of forest restoration. And sometimes for several hours under the sun, moving logs and stuff, it's pretty strenuous work. And I've been like on the ground and I come up fast and I feel dizzy, I feel fainting. You may have felt syncope also sometimes. When it happens, when we do that sudden movement up, it's like the brain stayed down there, okay? And I feel that faintiness. And at first I didn't know what was happening. So I mentioned it to my GP on my next physical, and he said, sure enough, that's your heartbeat, that's your low resting pulse, and so on and so forth. So he gave me the full explanation, and that's what it is, okay? So anyway, advantage as young, but disadvantage as the old, which, what does that mean? Now, diagnostically, because Dr. Martinez mentioned the pacemaker, it means that I may qualify for a pacemaker soon. Now, I'm 69 in December, in November, I'll be 70, which, I mean, when I became 50, I said life begins at 50. Then when I got to 60, I said life begins at 60. I went for my first PhD when I was in my 40s. I went for my second PhD when I was in my 50s. Now, in November, I'll say life begins at 70, okay? In other words, I feel full of life and ready to go, but I may qualify for a pacemaker soon. And then the next question is, it's not without, the reason why I say all this is because it's not without its bioethical implications. When you put a pacemaker on a person, the bioethical question is, when are you going to disconnect that pacemaker? Because like Dr. Martinez said, they had essentially a cadaver in front of them, but the heart was still ticking because the pacemaker was stimulating the heart, okay? And so to turn off that pacemaker doesn't necessarily mean killing the patient. It means that accepting that the patient is already dead, and now we have a cadaver and whose heart should not be beating. Which leads me right into the second, the alternative criterion for the determination of death, which is going to be a neurological criterion. So we have the classical, which is cardiovascular, no breathing and no heartbeat. But we also have an alternative determination of death, neurological, which is the second lecture coming up very soon. All right. Other unconscious states, other seizures that are non-epileptic, maybe the diabetic coma could be put in here. Locked-in syndrome. Let me just say a couple of words about locked-in syndrome, because functionally it's a little bit opposite to PVS, all right? The big one for us bioethically, I can tell you, is PVS, precisely when the person is hooked up to a feeding tube for years at a time, maybe even decades, but the person is not dead, all right? So obviously bioethical issues come up. But this one functionally is kind of the opposite, locked-in syndrome. Locked-in syndrome is the person is fully aware, or at least partially aware, not comatose at all, 9 or above on the scale, all right? Could be a 15. The person is fully aware, but cannot move or communicate, right? One aspect of aminolateral sclerosis, right? ALS, also known as Lou Gehrig disease. Lou Gehrig, ALS, some famous people have had it. And when a person is in ALS, it's a very tragic thing because their bodies are slowly shutting down, their muscular system, neurological system is shutting down, but they're fully aware. The mind is fully aware, and they cannot express. At some point, it's basically just blinking is all they can do, just blinking. I know that Steve Hawkins, for example, a brilliant astrophysicist, got into, eventually was diagnosed with ALS, aminolateral sclerosis. It's a disease of the neurological system that affects the voluntary nerves, the voluntary muscles, the skeletal system, and musculoskeletal. At one point, all he could do was just blink or even just move his eyes. And he had some kind of very sophisticated computer screen and that was synchronized with a camera that would focus on his eyes. And the movement of his eyes, with moving his eyes, he could literally write. He could translate that movement into writing or into some kind of communication. And then that writing, I think, may have even been able to be translated by the machine, by the computer, into speech. But that's all he had left in his toward the end of his life. Anyway, I don't really know. Again, doctors, if you could, is ALS a type of locked-in syndrome, or are they separate? Because they seem to have the same symptoms.
I don't know.
I don't know.
Wise.
I don't know. But anyway, at least if they're separate, they're kind of parallel, right? Because the person is aware, but cannot move, communicate, typically just the eye or maybe just blinking. Very challenging, but it's not PVS. It's the opposite, because functionally, they will be here. Okay. All right. That's it then. So the three diagnostic tools that are available today. Yeah, sorry.
I have a question.
Yes.
Regarding the activation,
Where are you?
About,
A locked-in syndrome?
we're talking about the pacemaker, no? The activation of the pacemaker.
Oh, pacemaker?
So
Okay.
Yeah, this is an ethical question. I have many patients that they have defibrillator and they have pacemakers.
Uh-huh.
Situation is at what point of their disease they can deactivate.
Exactly. Yeah.
Even though they are not dead, because it's not the
Right.
case, they are home, but they are on any stage.
Yep.
Whatever disease is, could be a cancer, it could be a dementia, could be at what stage of the illness
Yes.
is morally accepted to deactivate the pacemaker of the defibrillator.
Right. Okay. So this is where I think that this bioethical language of assisting or substituting the same machine, the pacemaker, just like event, could be assisting in one case and at some point passes on to be substituting. Okay. So we can make this case, I believe we can make the bioethical argument with a number of protocols, of clinical protocols, that they start as assisting, but over time, they become substituting. All right, so at what point is the pacemaker no longer just assisting the heart, but actually substituting the heart? It's a very difficult decision to make, but it has to be made. And that's why we look at the whole patient, the comorbidities, are other, is there systemic shutdown? Are other vital organs shutting down irreversibly? See, if other vital organs are shutting down irreversibly, the death process has begun. And at that point, it may be that the pacemaker, which started originally assisting the heart, has now gone on to substitute the heart functionally by continuing to stimulate the heartbeat, right? But the rest of the body is dying organically. And so at that point, we're no longer prolonging life, we're actually prolonging death because the death process has begun. So what I'm trying to say is we have to look at the whole patient and all of the comorbidities that are going on and all of the organ systems, which one is failing? Are they on renal failure, etc., right? And that's the point. So typically they're older patients and we know that they're heading toward systemic shutdown, but not all organs will die at the same time. But all you need is one vital organ to begin dying, imminently or irreversibly. The death process has begun. So it sheds some light. You still need the clinical eye for that patient, and you have to go individual by individual, right? But what I'm saying is that, at some point that pacemaker needs to be disconnected okay? Because it's keeping the heart pumping artificially. And it's become extraordinary. So this is other language that I'm precisely introducing. Say, we talk about in bioethics, we talk about ordinary versus extraordinary means, or proportionate versus disproportionate. But clinically, you talk about standard practice or experimental treatment. In principle, a pacemaker is what? It's standard of care. You know, if the heart is having arrhythmia or something like that, the standard of care is a pacemaker to regulate the heart. But we have to make that translation from clinical to bioethical, because it's at the bioethical level that we make the decisions, right?
Very clear, Father. Thank you very much.
All right. Okay. So this language. All right. So I want to introduce, now we're going to go a little bit in trying to bridge that gap between medicine and bioethics. The diagnosis, which is the current state of the patient, clinically, what does the patient have? You know, what are we going to code for when we send the bill to the insurance? Right? What is the diagnosis, which leads to a prognosis? Once we have a diagnosis, then we can say, okay, well, what is the hope of recovery of this patient? It varies. That's why you have to go patient by patient, because you're looking at a dozen organ systems that need to be working in concert, right? And they don't always do that, right? So diagnosis first, followed by prognosis. Then it's a question of managing. So we have some pathology that has been diagnosed, or a number of pathologies, and each pathology will have a protocol, right, or not. So now we're talking about management or relief. When it comes to the more psychological, if you will, all right, a patient may or may not be in pain, and they may or may not be suffering. So these are two different things, but typically, again, in the medical field, you see them lumped together. All right. So a person may be in pain, but not necessarily suffering, and vice versa. I'm going to give you a kind of a drastic example in my mind. Anyway, a couple is having their first baby, right? She's in labor, and he's right next to her. She's in pain and he's suffering. Okay. Yeah, she's obviously in pain. There are very few exceptions. Once I had a lady in the parish where I was many years ago, and I don't know how the conversation came about. She knew I was a bioethicist and so forth, and she just told me in passing, Father, for my first child, I was in labor. And my doctor just told me, push, and I pushed, and the baby came out, and I really never had pain. You know, that means that she had perfect dilation. So, but it's definitely an exception. And we both laughed because she knew with subsequent births that the typical thing is the pains of labor, right? The pains of labor. So definitely the normal mom will be in pain when she's in labor, but she's not necessarily suffering. She's actually happy that the child is finally coming out and will be able to see the baby, you know, for the rest of their lives. So, but the husband who is right next to her, zero pain, physiologically speaking. He's not in labor. But he's definitely suffering, right? Because he's watching her in labor, screaming her head off. So that's a graphic example where you can have pain without suffering and vice versa. But generally, they tend to come together, all right? And so because we are the whole person, again, the holistic view of the human person, right? Body, mind, and soul together. And therefore, how to deal with the pain and or suffering, because different people have tolerance to different degrees of pain or suffering. Some people, just by hearing that they're going to get an injection, they're already freaking out because they can't stand needles, all right? Or someone going to the dentist, they can already hear the drill and it's just a checkup, right? But that's all psychological. No one has touched them yet. Other people have tremendous tolerance for pain. And even after the appendectomy, I know a relative who had an appendectomy under emergency situations, and he decided to ride out the post-op and didn't take any pain medication. Of course, he was laparoscopic, so it was minimally invasive, but he was cut up a little bit, and he decided not to take the pain medication. So he rode out the pain, just tough it out. Anyway, that's part of the management, right? So from the Catholic perspective, and also from the human perspective, there's this document, Decree on Euthanasia. The Decree on Euthanasia, because we're going to have another lecture, I think in a couple of lectures, we'll talk about euthanasia and physician-assisted suicide, right? Which is actually legal in about a dozen states in the United States right now. Well, early on in Europe, euthanasia began, which is the killing of a patient, not allowing the patient to die, but actively killing the patient, put them out of our misery, all right? And so the Vatican came out with a statement, which is this decree, as you can see here, in 1980, precisely because in the 70s, a number of European countries were legalizing euthanasia, all right? And the core of the document, which came out from the Congregation for the Doctrine of the Faith, yes, at that time, the prefect of this congregation, in other words, the director of this congregation, was Cardinal Ratzinger, Joseph Ratzinger, who later, when Pope John Paul II died, became Pope Benedict XVI. All right, so at that time, it was Cardinal Ratzinger who was the director, the head of this congregation, who looks at precisely what the word says, the doctrine of the faith, maintaining the Catholic faith on this bioethical issues and other doctrinal issues. And the core of this document is, it has two main parts: the value, the intrinsic value of human life, right? And then it talks about euthanasia, which is essentially inducing death for compassionate reasons, for the sake of suppressing suffering, all right? But then there is this third part, which is very, very valuable. The meaning of suffering. The meaning of suffering for Christians and non-Christians, okay? So in other words, kind of jumping to the punchline here is that there is value in suffering. It doesn't mean that we look for suffering, all right? But when suffering comes invariably with time, all one needs to be is alive for some suffering to come at some point. For example, it is normal that we bury our parents. Tragic is when a parent has to bury a child, right? But normally, because the clock only goes forward, the standard, the norm is that we end up burying our parents sooner or later, and that is going to cause some suffering, whether we want it or not. So what to do when suffering does come? There is redemptive value, what we call redemptive value in suffering. If we're able to offer it up in imitation of Christ, yes, on the cross, through his passion, there is suffering, because it's precisely through the passion and death of our Lord Jesus Christ that we are redeemed. We are redeemed from suffering, and we're redeemed from sin and even death, because the event of Jesus did not end with the cross. It ended actually 3 days later with his resurrection, which is actually the beginning, a new beginning into eternal life. All right. So bottom line, death is a transition, but it's in transition to another state which is infinitely greater than the current state of affairs here on earth. All right. And Jesus has shown us the way. And that's why we say that he is the way, the truth, and the life. And therefore, he can be a source of solace and consolation when that suffering comes. If we're able to offer it up, then that has redemptive value, so that it's not wasted. So in the face of suffering, we can either despair or get angry and grind our teeth and blame everybody else, or we can accept it, move forward with hope that at some point the suffering will end, and either for us or for our loved ones. But that ultimate destiny is really eternal life, okay? Eternal life. So it puts it in perspective, of eternal life. So I recommend reading the document. It's long, it's only a few pages long, but you know, it's been out there for over 40 years and many people don't know about it. So now you know, okay? Read it, share it with your loved ones, and we're always trying to spread the truth and spread the good news. That's why we call it good news, gospel, good news. Okay, and it was also mentioned last lecture that at some point we need to do the burden benefit analysis. Again, I think it was in the context of pacemaker or some other protocol. At what point that protocol is now substituting has become extraordinary, right? We need to do the burden benefit analysis, and that's when we can use this document of the ERD. And here are two specific ERDs that speak of burden benefit analysis, all right? So Directive 32 and Directive 33, remember, you can just go to the website and pull it down. Even right now, we can just do this. All you need to do is punch the first couple of words: ethical and religious directives. There it is. All right, and then you want to look for this site, USCCB. Always read the address, right? Always read the address, the website address. United States Conference of Catholic Bishops. This is the original document. Just click in, there it is. The blah, 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 has the 6 parts. And we're looking at part 3, which is the relationship between doctor-patient relationship. Doctor-patient relationship is the 3rd part. So keep scrolling down. And the directives generally are in the 30s. They kind of match up. Here it is, part 3. Always has a little introduction. And then the actual directives, it begins in the 20s. All right, we'll move on. I think 32 and 33 are the ones that we're looking at. These two here. Okay, that's the actual document. So I just copy them here for ease. While every person is obliged to use ordinary means to preserve his or her life or health, because this is broader than just this is not end of life. This is professional patient relationship, doctor-patient relationship. Okay, so just healthcare, general healthcare. Every person is obliged to use ordinary means of life support. No person should be obligated to submit to healthcare procedures that the person has judged with a free and informed conscience, not to provide reasonable hope of benefit. So here's benefit, without imposing excessive risk and burdens on the patient or excessive expense to family or community. All right, so here is the benefit burden analysis. All right, if it doesn't offer reasonable benefit, and if it actually imposes an excessive burden, then guess what? That procedure, that means, has become extraordinary. all right, is excessive. So here's language, burden benefit analysis. Yes, clinicians should be familiar with this kind of language. Ordinary or extraordinary, it's more bioethical language, all right?
Father?
Yep.
If I could make a quick interjection at this point, because I know it's going to come up in future lectures.
Mm-hmm.
This particular section, the 32,
Yes.
has been something I frequently have to go back to and so on.
Mm-hmm.
And I think it's very germane to the polemic that we have or we've had concerning the vaccinations during the pandemic. So I would tell everyone just to keep this one in mind as we go forward in the course.
Right. Vaccinations, because, you know, when you talk about vaccination, especially in a pandemic situation, even just epidemic, then we have to enter public health, right? And public health is a subset of healthcare, all right? But it's a big subset. And public health has its own dynamics and its own rules because there's more government policies that apply and so forth. Yes, so I would just like to add, when you talk about vaccination, I would also add another spin to it, which is public health, right? And so, yes, burden benefit analysis. One thing is to talk in general about the general population, what is good for the general population. And another thing is to talk about, well, how about children? Should they be vaccinated or not? For the good of not the children, but for the good of all the people, for the good of adults reaching the herd immunity of 70%? No, because, you know, now we're using children for not their own benefit, with the risk, because every vaccine has some level of risk, including getting the disease. Okay. So anyway, thank you, doctor. I just wanted to add more complexity to what you're saying.
Father Chofi.
Yes.
So I have a question related to this. So let's say that, well, Enrique have to go to this procedure. Thank God he was able to do it. But if we did not have the insurance to cover it, wow, and it would be very expensive. It didn't happen. I'm just saying.
Thanks be to God.
I'm putting a person that is going through some kind of situation where life is at risk. If the procedure is not done, the person is going to die. Yeah. And again, the process of dying begins, but technology advances, whatever, but they don't have the means, the financial means. The family or the person decides not to go under the procedure, even though there is 90% possibility of saving their life. Is that bioethical wrong? Or right. what is saying here that is okay?
All right. So without violating HIPAA and the confidentiality of your husband's condition and so forth, but I think we can speak a little bit in general terms. I always, one thing that I tell my students and I tell myself are the examples that I'm posing, are they realistic? Because and the priest in the course can vouch for this and can certainly agree to this, that sometimes in philosophy, in theology, and in bioethics, we can stack it up and we can come up with such hypothetical scenarios that are so unrealistic that they really would never happen in human life, okay? But we can really stack it up hypothetically. Well, what if this person had this condition and there was this treatment, but there was no insurance for it, and we just load it up to make it basically impossible, all right? And then I always ask the question after the whole, they say in baseball, they say we load the bases, right? So you got a person on first, a person on second, a person on third, and you're the fourth batter. And the pitcher has a perfect score, has a perfect score, has struck out every, so it's all on you. You either bring him home or you lose the game for your team, right? Load up the bases. But so how realistic are those scenarios? That's why we always have to depend on the clinicians to ground us in reality. So the first thing, as you were describing the case, Christina, and it seems like it was something serious that was not just a threat to health, but a threat to life. And again, words, one thing is to talk casually with family and friends and strangers, and another thing is to talk bioethically. I'm always cautious when I'm speaking bioethic. I'm very conscious of the words that I'm using. I'm trying to really select the best words possible to convey the meaning that I'm trying to convey. So one thing is a threat to health, right? But when it's a threat to life, then you just bump that up a notch, because acne could be a threat to health, but it's not necessarily a threat to life. But appendicitis is a threat to life. All right. So there's a procedure. So we're saying a patient, ex-patient, and the patient has a pathology that is a threat to life and does not have the insurance to cover it. My first reaction is take that patient to Jackson Memorial Hospital, take the patient to a public hospital or even a private hospital and present to the ER. I understand that legally they have to intervene. They have to take care of the patient, and then they'll work out the payment one way or another. In the public hospital, actually, I think they have the right to be treated. In a private hospital, they may be charged hundreds of thousands of dollars, and then you pay $10 a month for the next 200 years or something like that. You make a payment plan. But basically, I think, and again, we are so fortunate to have clinicians in this cohort. When a patient presents to ER, they have to be at least assessed, evaluated, and a diagnosis hopefully will come out of that, right?
Yes, correct. There's a law called EMTALA, which is emergency medical treatment, which applies if you go to the emergency room, they have to evaluate you, treat, and stabilize you. They can't refuse you for any reason.
Exactly.
Not to treat you.
Right. Then we'll fight about the payment.
But then they'll fight about the payment. The Jackson is actually Miami-Dade County Public Health Trust. So it's codified into the county ledger that we all invest. Everyone who is a resident of Miami-Dade County all invest to maintain Jackson as a trust, and they are obliged to treat all residents of Miami-Dade County, regardless of ability to pay or not, or not.
So we're already kind of prepaid. We've prepaid into that plan.
Exactly.
Just by paying taxes here in the county.
Being a resident, right? So they will ask you for 2 telephone bills with the same address or your driver's license, and it's something that identifies you as a Miami-Dade citizen county. Palm Beach has a similar program. Broward County is a little bit different.
I see. Okay, so it really comes down to county legislation and so forth, county ordinances. Yeah. Right. Okay. So you see, there is that, right, Christina? But then there are other layers of complexity. It may have to be. You mentioned, doctor, that one has to be a resident, but we also see in Jackson, because I've been at Jackson many times. For a number of reasons. And sometimes we see indigents also, we see undocumented people and so forth. We see, tragically, a lot of the homeless tend to gravitate in that area. And so, yeah, they just have to take them. They have to take them. But however, to try to follow your argument a little bit more, there is a procedure. The person cannot afford the procedure, that may fall into this category. It's become an excessive expense. It's also considered an excessive burden. All right. So there's provision for that. And bottom line, in good conscience, a person may, in good conscience, opt out, decide, well, I'm not going to go through this procedure. But then we have to see how serious it is and so forth. Is it a vital organ or any number of them that are really failing? Could it be that the death process has begun? Okay. There are tough questions. They're very personal questions, right?
Thank you, Father. Thank you, Doctor. Thank you.
Yeah, sure. Let's look at 33. The well-being of the whole person. This one speaks to this holistic view of the human person, right? Body, mind, and soul. And we know that people of faith also tend to heal better, faster, because somehow the human soul, the human consciousness, conscious has an influence into metabolism. So we look at the whole person when deciding about any therapeutic intervention or use of technology. Therapeutic procedures that are likely to cause harm or undesirable side effects can be justified only by a proportionate benefit. See, this is proportionate language, proportionate benefit to the patient. So this is definitely bioethical, philosophical, theological language, all right? And so there's a sort of scale here, if you will, that procedures that go into experimental procedures. Some cancer treatments are experimental, it's not standard practice. Then that is a greater burden and need a proportionally more serious reason for justifying it. Okay? So in other words, these two together basically are in favor of the patient, of the conscience. But notice embedded right in the middle of it is informed conscience, right? So we have a responsibility to form our conscience. Again, going to the added value of the course, Latin, conscience comes from cum scientia, from the Latin cum scientia, which is with science, with knowledge. Science or knowledge, and that's why we're all in this course, right? We're all in this course together, trying to learn and work our way, navigate our way through human healthcare, especially at this point at the end of life, right? So we are informing our conscience. I include myself. I always learn something when I teach these courses. All right. So at some point, we may withhold or withdraw life support system, okay? And when? The question is when. Could be event, it could be a dialysis, it could be the pacemaker, it could be the insulin pump, okay? Any of those, when to withhold or withdraw. Withhold is never to use it to begin with, or withdraw is once the procedure has been instated on the patient, when to remove the machinery or the protocol, when to stop. All right, okay. Questions, comments? So I think it's a good time to break. Look at that, 11:49. So at 12 noon, Miami time, I'm going to start on the second part, which is the determination of death. And we've kind of covered quite a bit of it anyway, in anticipation, but we'll go through it a little more formal way, systematically. And so I'll leave this one projected and take a 10-minute break. All right. Back by 12 noon. So let me pause here. Okay, my Miami clock says 12 noon, so I'm starting up again. Before going forward, any questions or comments from the previous lecture on various states of unconsciousness, and then some of the bioethical analysis we did. We're going to pick up on that bioethical analysis toward the end of this second half, ordinary and extraordinary means of life support, assisting versus substituting vital organs, okay? So we're going to pick up on that. Right, now we're going to look at the determination of death. In other words, at some point, we're looking at bioethical issues toward the end of human life. So we have to be able to determine when is that end, when has that end happened? All right, when has human life actually ended here on Earth? Okay, and so that is a question that again falls within the competence of the medical profession. In other words, is the doctor, is the healthcare professional who determines when death happens clinically, or once death has happened. And within that, so this whole issue of ordinary versus extraordinary means of life support is also part of the bioethical language. We'll pick it up on the way. So first, I want to talk about the determination of death, what is known as the Uniform Determination of Death Act, or Udda, which is just the acronym. All right, and let's look at that. So this is what is known as a model state law, and it was approved essentially by the 50 states of the United States by 1981 in stages, because it's at the level of each state. All right, these are really state laws, and there's regulation. And just like there was another example that we ran into, but yeah, basically before 1981, bottom line, one could be alive in one state and dead in another state, the same person, the same condition. Okay, obviously the one who is alive is barely alive, but it's alive. Whereas in another state, by that same condition, that same diagnosis, that person would be declared dead. So there was no uniformity, is what I'm trying to say, among the 50 states of the US. Now, you can think that that represents a lot of problems, okay? From one state to another, to not have uniformity in the declaration of death has all kinds of negative implications with regards to the transport of that body, for example, from one state to another. It's going to have legal implications. It has implications for inheritance. When does the will kick in, and so forth? Many, many implications. And so there was really a need for a uniform determination of death in the United States, all right? And amazingly, up until 1980, there was no such creature, all right? So that one could literally be dead in one state and alive in another state. So there are 4 agencies, 4 commissions that were involved in this process. First, at the federal level, there is this National Conference of Commissioners of Uniform State Laws. So think about this for a moment, think of this phrase. There are commissioners on uniform state laws. In other words, these commissioners have been commissioned, have been entrusted with the uniformity of state laws. In other words, state laws that go across state, all right, that apply to all states. And there are a number of these. I'm not really very familiar with them in details. Lawyers will know about this a lot, all right, but also government officials, state legislators, for example, all right? They need to know about this because certain laws need to be uniform. For example, interstate traffic laws, right? The I numbers, I-95, I-75, I-10, those are all interstate highways, which means that they go from state to state. Imagine if in one state, in Florida, one drives on the right side of the yellow line, but when we go into Georgia, all of a sudden the traffic goes in the opposite direction. One is supposed to drive on the left of the yellow line. Well, that's going to be chaotic, right? And especially for an interstate that's going through states with a certain uniformity. So there has to be uniformity of traffic laws from state to state for the interstate highway system. It's the federal system, right? So there are these commissioners that look for the uniformity of these laws across states. And some have to do with health and some don't have to do with health, at least directly, but indirectly, yes, like traffic laws, all right? Or driver's licenses, that a Florida driver's license is valid in Alaska, at least for a certain amount of time, right? License plates also, eventually the license plate needs to be changed to that state, but one can drive for maybe 1 or 2 weeks with the plate of another state, etc. Anyway, you get the point. With regards to death, this was probably one of the most critical ones, okay? So this national conference took up the charge of finding a uniform determination of death. They consulted 2 main agencies or associations that are also national, the American Medical Association, AMA, and the American Bar Association. They're a little different because the American Medical Association is one of these professional associations for medical doctors, but not every doctor has to belong to the AMA. I know a number of doctors who are not belonging to the AMA because lately the AMA has become very utilitarian and has kind of been infiltrated with agenda and issues. And so a number of doctors in principle have dissociated from the AMA. They're not members, okay? That's a position of conscience. Different from the ABA, because I believe, I'm not fully sure, we don't have any lawyers in this cohort, but maybe somebody knows. I think that for a lawyer to be able to practice within the state, they have to have passed the bar for that state. So a lawyer to be able to practice or have a license has to be past the bar of that particular state. And I believe it's the American Bar Association that manages the bar, right? What they call the bar, which is a state exam, okay? And there may be many questions that are the same for every state. I'm talking about legal things, but you can see also that because there is also a state legislature, there is also a state constitution. We talk about state constitutions. There are also laws that are particular to states that are not uniform. And that's why lawyers to practice have to be licensed in that particular state, all right? And those are, as far as I know, they're not transferable. So there are some differences between the purpose of the AMA and the ABA, but at the end of the day, they are large organizations that cover either the clinical aspect of healthcare in the US or the legal aspect, even of healthcare, all right? So determination of death has impact medically and has impact legally. So these were consulted, and also another one that was consulted was the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research. That's a mouthful. That's a huge title, probably the longest title that I've seen for any commission or group, but that's put together, as the word says, by the President. So each president, I'm talking about the President of the United States, the fellow in the White House, each president puts together their commission. And so President Biden has his own commission. And before that, President Trump had his own commission. And before that, President Obama has his own commission. and George W. had his own commission and so forth. Each president puts together his or her own commission of issues of experts to deal with biomedical and behavioral research, all right, and in medicine. Okay, so these three agencies were consulted by this other agency, and finally, this agency came up with a wording that was then sent to each state legislature for passage. And it began, I think, in the late 70s, and they went from state to state, and eventually all 50 states, the last one, I don't know which was the last one, but it was in 1981, approved the language of the determination of death, and that became the Uniform Determination of Death Act, otherwise known as Udda or Udda, whatever, however you want to pronounce it. And it turns out that there are two alternatives. In the determination of death, there are two alternatives. Either irreversible cessation of circulatory and respiratory functions, in other words, no heartbeat and no breathing, or irreversible cessation of all functions of the entire brain, including the brain stem. And then notice the redundancy on this alternate determination. Notice the redundancy. All functions of the entire brain. And just in case somebody is not clear what constitutes the entire brain, it includes the brain stem. All right? So either one is acceptable for declaring a person dead. To be clear on the biology, because again, we build on nature, right? This is the brain, the cerebrum, the two hemispheres, which includes the cerebellum functionally, right? You can see it connected here. Whereas this is the brain stem. Typically, it is the pons and the medulla, however you want to pronounce it. So we know that this controls voluntary function, especially the cortex, the different lobes of the brain, whereas the brain stem controls the involuntary nervous system, which includes heartbeat and breathing. All right. So standard criterion, which is also known as the Cardiopulmonary Criterion, no heartbeat and no breathing. Whereas the neurological criteria, it has to be total brain death, what we call total brain death in bioethical language, not partial brain death. And that's why I have a little X here, not partial brain death, not acceptable. Partial brain death would be only the cerebral cortex. Because imagine this, when we go here, this would be partial brain death, you see? So a person in PVS under partial brain death would have been declared dead. But their heart is beating and they're breathing on their own. And that's why we took a big breath of relief, we bioethicists, when this commission proposed for the definition, the alternate definition of death, the neurological criteria, that it would be total brain death. And this is accepted. Thanks be to God, by the AMA, the ABA, and all those who are concerned officially in healthcare and in determining death in the United States, okay? And so we were relieved because there was a push from some group, there was a push toward just partial brain death to be the neurological criterion. What's the big advantage medically for partial brain death? What team would have a vested interest just from the secular, utilitarian, pragmatic, from the pragmatic point of view? What medical team would have a vested interest in using partial brain death for a criterion of death, for declaring a patient dead.
I think transplant teams.
Absolutely, the transplant team, right? Because if you declare a person in PVS dead, their heart is beating, their lungs are breathing, and you can harvest that, and you have a living heart transplant, okay? Or living lung, literally breathing or palpitating. So, but if we take out a living heart from a patient, we are killing that patient. We're not allowing that patient to die, okay? So partial brain death was a big no-no, bioethically speaking. Big red flag, and thanks be to God, but you know, we're not the only group in town, right? There are other groups that are utilitarian and were pragmatic and had their own opinion. And there was a push for that, but thanks be to God, people with great clarity saw through it and said, no, we have to take total brain death, because taking out a living heart, a beating heart, is not letting the patient to die, letting the patient die, it's actually killing the patient, all right? So you're clear, it's really pretty straightforward. There are two criteria, one or the other, but on the neurological one, it has to be total brain death, which includes the stem. And the typical thing, which is an EEG, right? Not an EKG, which is an electrocardiogram. This is an electroencephalogram, the EEG. In other words, this fellow here has to be flat. This is not flat. This is normal. This is normal. This is abnormal. What they say a flat line, you know, flat line is horizontal flat. And even that is not sufficient. It's can be flat for a period of time and then kicking again, all right? So it's not that easy, but at least a flat line. And then if you, in extreme cases, there's some doubt, you repeat the EEG 24 hours and you still get a flat line, well, that's pretty conclusive. But either criterion may be applied. Still, there's some controversy around the neurological one, but the vast majority of people in the know accept it, including theologians. All right, so we have now two criteria, because you see, who determines death? Even for legal purposes, who determines death is the clinician, right? Which doesn't have to be an MD, it can be a DO, and it can also be a nurse practitioner, I believe, right? A nurse practitioner can also give a declaration of death. But it has a legal implication, and it also has existential implications, because now we can bury this person, because this person is no longer a person, is now a cadaver. So going forward, I want to, and again, looking at the whole person, right? Looking at the whole person, I want to shift gears a little bit into the more theological, philosophical, theological, and the process of dying, right? I've been emphasizing the process of dying because of the trillions of cells that don't all die at the same time, and the dozen organs that don't all die at the same time, vital organs. When we put it within the context of faith, in other words, the whole person, body, mind, and soul, right? This is more of a philosophical principle, and it's a little tough to grasp for non-philosophers and non-theologians. So in this sense, I'm going to say that for our cohort, now the priest will have the advantage. We priests will have the advantage here, because for years we have studied this more formally in the seminary. In fact, you know, generally the seminary, which is the training for Catholic priesthood, is normally 4 years of philosophy, a bachelor's in philosophy, you know, after high school, and then 4 years of theology. and sometimes even an extra year of pastoral ministry somewhere. Typically, they embed it somewhere in theology, but it's minimally 8 years of training. So it's equivalent to a medical doctor as far as formal academic training is concerned. And that's why you hear me say that philosophy is the tool that we use for doing theology, right? But theology adds the argument of faith and the argument of God and the supernatural and what in philosophy we call metaphysic realities, going beyond the physical world or the physical universe. Anyway, let's think about this a little bit, all right? Something that is of value, human life is of value, right? We value, we treasure human life, and that's why we preserve it. Think of medicine. How do we justify the practice of medicine? Think about medicine. Think about the practice of medicine. It is diametrically opposed to natural selection, right? Because what do we do with medicine? We're enabling the weaker to survive. If medicine works, the patient is healed. They're restored to health. But that illness, that pathology was a natural phenomenon. It could have come by an accident. It could have come by an infection, et cetera, but now the patient is unhealthy, is suffering some pathology. The natural course, certainly for the rest of nature, for other animals and even plants, because plants also get diseases, right? And suffer accidents. The course is if they don't survive, they die, and so it's survival of the fittest in nature. And our human nature is part of nature. And so the practice of medicine, it counters natural selection. And yet, we're not going to stop the practice of medicine. We need to promote it, encourage it, and move it forward. So how do we justify, philosophically, how do we justify the practice of medicine? If it's against natural selection, we can say that in a sense, it's making our species weaker, especially when the practice is within the reproductive years, right? Let's say overall, I'm going to throw a number out there. Any medical procedure on someone who is 50 years old or less may be weakening our species, right? Because without the medicine, that person may have either died or not reproduced, which, as far as natural selection is concerned, is a positive thing, because then whatever pathology that person had, in principle, is not passed on, right? So how do we justify the practice of medicine? Really, quite simple. We're capable of the good. We're capable of desiring the good. It's called benevolence, bene volere. Bene volere is to will the good. We're capable of willing the good, just like we're capable of willing the evil, right? We're capable of willing good things to our family and friends, and we're capable of willing evil things to our enemies. We should not do it, but we're capable of it. All right. So the will is capable of either willing good or willing evil, right? So that's benevolence, to will the good, bene volere. We're capable of doing the will, of willing the good, and therefore we should do the good. We should do it. If we're capable of doing it, we should do it. And that's beneficence. Bene facere, to do the good, all right? Bene facere. And so, because we're able to will the good and we're able to do the good, then in conscience, we should do the good. It's according to our nature. It's according to our nature to do the good. And so we practice medicine because of beneficence. We're capable of healing a number of things today, illnesses, diseases, accidents, etc. And therefore we should do it, right? And that's principle bioethics. I mean, that's squarely into principle bioethics, right? So life is a fundamental value. Another word for fundamental is a basic value. Human life is a basic value, but it's not an absolute value. And this is a philosophical distinction that you may say, well, he's splitting hairs. No, but this is a very critical hair. This is a very important hair. It's like the only hair that's left in my head, okay? This is a very critical hair. I still have one hair. All right, so fundamental, yes, we should do everything possible to preserve human life because it's a basic good, it's a basic value. But we're not obligated to do the impossible because human life is not an absolute value. If human life were an absolute value, then I would be obliged to do even the impossible, which is not possible by definition. So you see how philosophy can get into some mental gymnastics, okay? Right? But what is absolute value? What absolute value is eternal life and eternal salvation. That's absolute value. So there's a contrast for you. This life on earth is going to end sooner or later. So no matter how much I do to save my human life, sooner or later, death is going to win. That's why St. Francis, little saying attributed to St. Francis of Assisi, be reconciled with sister death because she always wins. All right, come to terms with our death. And that's why you see some saints in paintings, in classical paintings of the Renaissance and the Baroque, you see the saints looking at a skull, right? It's not that they're morbid, it's that they're contemplating their own death. They're reflecting on their own death, on their own mortality, all right? It makes us a little more humble. But what's beyond the skull is eternal life, right? And that's an absolute value. So we should do everything possible and the impossible, anything that's required of us to have access to eternal life, okay? But life here on earth, we know that sooner or later, no matter how much medicine and how much health, exercise, et cetera, we do, it's going to end sooner or later. And so it's a basic fundamental value, but it's not an absolute value. We're not obligated to preserve it, as they say vulgarly, come hell or high water. There's a limit. There's a limit. Okay, and the limit is pretty much the life expectancy, which for women, I was just looking it up before the break. For women, it's about 81 years of age in the United States. That's an average. That's just a statistical average that serves as a guidepost. It's a woman less or more than the average lifespan for women in the United States. Obviously, we have to go country by country because of healthcare availability. Even within the country, we could also go by regions, right? Region by region. Some regions have more access to healthcare than others, etc. For men, it's about 76, more or less. This is average. Combined is 79, but the combined is meaningless. Again, think functionally, existentially. There is no combined human being, right? We either male or female genetically, even if we want to transition, we cannot change the sex of each cell of our bodies. And so the combined is just there for insurance purposes or whatever. But what counts really is within the sex, whether male or female. Okay, so those are the numbers. And they're useful when we look at end-of-life issues. Is the patient who just collapsed in front of me a 20-year-old or a 90-year-old with regards to CPR, all right? If they're 90, they've gone 10 years beyond the average lifespan. So they've actually lived a full lifespan already. It's just one factor, one other datum to factor into the bioethical analysis. Talked about this already. Also talked about this already, trying to bridge that language gap between bioethics and clinical. So I want to land here with two other ERDs, two other directives that are in the 50s, right? This is not age, it's just a number of the directive, 56 and 57. So they fall within the end of life section. the end of life section of the ERD, right? Bioethical issues at the end of human life. And so 56 states a person has a moral obligation to use ordinary or proportionate means of preserving his or her life. So you see the bioethical language, ordinary or proportionate means. And then, just in case there's a doubt, proportionate means are those that, in the judgment of the patient, offer reasonable benefit and do not entail excessive burden or impose excessive expense on the family, on the community. So you see the redundancy of language, right? Or the doving in of the language that we saw earlier in 32 and 33 is picked up here, but in the context of end of life, right? So what I want to point out is this, the judgment of the patient. In principle, it is the patient who decides, is this procedure ordinary or extraordinary in my particular situation as I perceive myself with my comorbidities. And that's why I'm saying it makes a difference to be on appendix failure or to be on renal failure, because the two protocols are very different from each other. One is essentially taking insulin, and the other one is going on dialysis. They're both vital organs, but you can see that one is much more tolerable in general than other. But it could be that the person with a failed pancreas, I meant pancreas, not appendix, I'm sorry. The pancreas may have other comorbidities at some point. And so in the judgment of the patient, conscience, we have to respect conscience, but we also need to form the conscience and to inform the conscience, right? So it is an informed judgment. And then 57 is just the reverse. In other words, a patient may forego extraordinary or disproportionate means of preserving life. And just in case, disproportionate means are those that, in the patient's judgment, do not offer reasonable hope of benefit or entail an excessive burden or impose excessive expense, the family or community, right? So you see the burden benefit analysis brought in, and the language ordinary, extraordinary, right? But the key here is the patient's judgment. And that judgment has to be an informed judgment. That's why we can all help our family and friends make these decisions. Again, just revisiting stuff that we talked about earlier, the 3 examples that I gave already on renal failure, the respiration and cardiac arrest. At the very, very end of the day, we have to answer this question. When we withhold or withdraw, is it this one? Yes. When to withhold or withdraw. All right. A minute. It's right here. Here we go. When to withhold or withdraw life support system. Are we killing the patient or are we allowing the patient to die? This is the bottom line bioethical difference, right? We're not allowed to kill anyone who is innocent. In other words, we may kill an unjust aggressor. That's a different story. That's called self-defense, all right? So an unjust aggressor, I have the right to defend my life. But I'm not talking about that. I'm talking about patients, innocent human beings. We're not allowed to kill patients, but we are allowed to allow them to die. In fact, we have to allow them to die, right? I mentioned this because there's going to be a spin, and I'll shut up in a couple minutes. But since we're going to go into euthanasia and physician-assisted suicide, that camp, those who advocate for euthanasia and or physician-assisted suicide, they're talking about allowing the patient to die. And we really have no argument to that, right? But it's a misnomer. It's not that they're arguing for allowing the patient to die. They're actually arguing for killing the patient. But they're talking about the perception and the publicity and the propaganda is about allowing the patient to die, you know, but it's not about allowing the patient to die. Euthanasia and physician-assisted suicide is really about killing the patient, okay? Or the patient killing herself or himself. Otherwise, it would not be physician-assisted suicide, okay? We'll get there. I'm just setting you up. I'm just prepping you for the lecture that will come in a couple of lectures. All right, so this is a key question here. Bioethically, obviously, we're not allowed to kill anyone, but we are allowed, in fact, we have to allow people to die. All right. That's it. Thank you again for your patience and your attention. As we move forward, as you can see, we're exploring the issues step by step. Now we have various states of unconsciousness, but especially PVS, which will come in handy when we look at PVS with a peg to the stomach. All right, persistent vegetative state and nutrition and hydration. That will be our last topic, actually. But also this determination of death will help with when we talk about euthanasia and physician-assisted suicide. Okay. If there are no questions or comments, I thank you all very much and see you next week, God willing. I think that next week probably we'll look at the different forms, consent and all those forms that have bioethical implications. All right.
Thank you, Father. God bless you. Thank you, everybody.
Thanks again, everybody.
Thank you, Father. Excellent class.
Bye, Father.
Thank you. My pleasure.
Bye all.
Bye.